Good afternoon, everyone. You guys have all made it. I first want to thank SAGES for the opportunity to present today and for another really outstanding, high-quality conference. It's quickly become my favorite time of year, and it's the best surgical organization in the world now. My name's Alejandro. I'm a surgical resident at Case Western here at Metro Health in Cleveland. And today I'll be discussing the laparoscopic management of gastrocutaneous fistula after a failed endoscopic closure. We have no disclosures, although our MIS division does provide laparoscopic, robotic, and endoluminal therapies. So historically, the management of gastrocutaneous fistula has been challenging, especially prior to the advent of minimally invasive surgery, which has reduced the morbidity associated with classic open procedures. However, as advances in endoscopic technology and therapeutic techniques has improved over the last 25 years, there's been an increased utilization of over-the-scope clipping, suturing, and other types of endoscopic therapies for the treatment of gastrocutaneous fistula. Initially, these non-surgical interventions were reserved for non-surgical candidates. However, there's been a practice shift over the last few decades, increasingly applying these techniques in patients who would otherwise qualify for surgery. This has been driven by the notion that these newer endoscopic options are less invasive, with some studies suggesting equivalent outcomes and similar technical closure rates as surgical management, with potentially lower complication rates, shortened hospital stay, and earlier resumption of an oral diet. While initial endoscopic closure rates appeared promising, especially for acute perforations in fistulae, in chronic fistula, recurrence rates in the same location has been reported as high as 46 to 77%, depending on the literature that you look at. At our institution, we've noticed an increase in referral for surgical referrals for gastrocutaneous fistula after failed attempts at endoscopic management, and we're going to be sharing some illustrative cases. The first case here is a 26-year-old male with a spastic cerebral palsy and a developmental delay. He had a previous lifelong G-tube, but had a persistent gastrocutaneous fistula after it was removed. There was a previous attempt at an endoscopic closure with tacking device. Their 4 helices were deployed in sequential fashion. They were cinched. They approximated the gastrostomy site. They did a leak test with methylene blue, and everything looked well. Their total procedure was about 62 minutes, and it worked for about 3 weeks, unfortunately, and then it came back. So at that point, he was referred to our surgical service. So we took him to the operating room. These cases tend to be kind of straightforward. We entered the abdomen and with an optical entry in the left lower quadrant, performed a tap block, and got another 5 and 12 millimeter port in. Take down, there's always some momental adhesions, and then you just get circumferentially around the fistula tract, and you're able to transect it usually pretty easily with a 60 millimeter firing of the stapler. The remainder of the specimen, that intra-abdominal portion, you just take it down from the abdominal wall. Here we got some, just take some more down. And in this case, you actually can see the tacks kind of getting taken out here. So, we then, once that intra-abdominal portion is done, we just focus on the cutaneous portion, just circumferentially excise it, fulgurate the rest of the extracorporeal and intracorporeal mucosa. We close our port sites in standard fashion with suture passer, and then just purse string the extracorporeal side and pack it with a betadine soaked Tefla. This procedure took about 75 minutes. He went home the same day on a regular diet, and he's had no fistula recurrence for the last 14 months. The next patient was a 29-year-old male, and he had a remote anoxic brain injury, and he had a previous PEG tube that was removed because it was leaking, and it continued to drain. He had a prior attempt at endoscopic closure using a suturing device, and there was technical procedural success, but again, he had early fistula recurrence. We took this guy to the OR, again, 3 trocars, and you can see some more adhesions here, and that's kind of the name of the game in these cases. After we're able to get these adhesions down, you're able to isolate the fistula tract. And once you're able to kind of get all the way around it, you just get your stapler across. Another blue load. You fire. Sometimes take some sequential firing. And then you're going to take it down again, off the abdominal wall. Fulgurate the internal part and external part. Here, actually, we're just checking. Sometimes a staple line can get a little, I just want to make sure it's hemostatic. And then, we closed it as described in the previous case. This case, the It took 38 minutes. It was also outpatient, and he went home on their normal diet, or sorry, tube feeds. But they've had no fistula occurrences. It's been about 16 months. By comparison, just to be fair, patients that come straight to us with persistent gastrocutaneous fistula, they also have pretty equally good outcomes. This is a 31-year-old female. She had ulcerative colitis and colon cancer and a GC fistula after her PEG tube was removed. Due to her persistent output and her failure to resolve with local wound care, she elected to pursue definitive surgical closure. We took her to the operating room, and the gastrocutaneous tract was observed in the left upper quadrant. Again, we took down those adhesions and were able to create a window. And once you isolate that fistula tract, it's the same thing. You just fire a stapler across it. Take it down from the intra-abdominal portion. You're going to fulgurate the mucosa, fulgurate the outside, close it, pack it, just like we described in the other cases. The total operative time was about 57 minutes. This is also an outpatient procedure. She went home on a regular diet, and she's had no fistula recurrence for about 13 months. This last case is a 64-year-old lady. She had head and neck cancer and a partial glossectomy with a PEG tube. She ultimately didn't require it, and she had some persistent drainage, so it was removed. She came to our clinic. She was taken to the operating room, and the abdomen was entered. Here, she had more extensive adhesions. That kind of ends up being the more tricky portion of the case. But ultimately, once you're able to identify the fistula tract, here you kind of deflect it laterally, just get your window in there. Fire a few staple loads. Take it off the abdominal wall. And here we're using different techniques. Here we're using some hot scissors. There's multiple different ways to skin this cat, but ultimately, fulgurate the intra-abdominal, extracorporeal portions, and it's done just like the other cases. This case was equally fast, 49 minutes, went home the same day on a regular diet, no fistula recurrence for about 12 months now. So in conclusion, while these novel endoscopic therapies have provided options for patients who are not typical open or laparoscopic surgical candidates, current failure rates for these chronic fistulas remain high, and you likely due to that chronicity of fistula and epithelialization. Minimally invasive surgical resection should remain the gold standard for definitive management of these chronic gastrocutaneous fistula after gastrostomy tube removal. Thank you.
That's great to see videos.